10 सारी फिंगर्स दिखाओ कितनी हो गई 10 5 फिंगर्स देखो 10 5 तो ये 5 फिंगर्स कितनी फिंगर रहेंगे 5 बोलो कितनी फिंगर रहेंगे 5 कितनी फिंगर रहेंगे और अब कितनी हो गई 10 2 दिया बोल
Dr. Kavita, can you hear me? Dr. Kavita, can you hear me?
Yes, ma'am, I can hear you.
Yeah, please start.
Yes, ma'am, we are starting. Hello, good evening, everyone. I am Dr. Kavita Sharma, Assistant Professor, Banarsi Das Chandiwala Institute of Physiotherapy. On behalf of BCIP family, welcomes you all here. As it is truly said, learning it is not. BCIP is here again knowledge on cancer rehabilitation. Ma'am and Dr. Ishani Hanspal ma'am share their valuable information on the cancer topic. Now, I would like to invite Dr. Nidhi Kalra ma'am, Director BCIP, to welcome our guests and to share few words. Please, ma'am, Dr. Nidhi Kalra ma'am.
Thank you, Dr. Kavita. On behalf of Banarsi Das Chandiwala Institute of Physiotherapy, under the aegis of Sri Banarsi Das Seva Samarak Trust Society, I welcome you all on this webinar. Forwarding the legacy of BCIP in bringing awareness about various upcoming diseases of concern and how physiotherapy can play a key role, we have organized this webinar. As we all know, and according to the World Cancer Report, estimated cancer burden in India in 2018, it was around 1.16 million new cancer cases were noted. And in India specifically, if we talk, according to WHO, 1 in every 15 Indian will die of cancer. And the most commonest cancers seen in India are breast cancer, oral cancer, and cervical cancer. So besides the medical management and the surgical management in the field of cancers, physical therapy also plays a very, very important role. You know, besides chemotherapy, radiotherapy, and surgery, which have been continuously developing to manage the cases of cancer, it has been seen that the survival rate has increased over the years. And physical therapy also helps patient regaining strength, physical function, and improve their quality of life, because many cancer patients are have various muscle weakness or pulmonary dysfunction, fatigue, and pain after their cancer. And we have tried to bring the best cancer experts, Dr. Alpana and Dr. Ishani. Thank you so much, ma'am, for accepting our invitation. And I hope the information shared with you will be very beneficial for all our delegates. On behalf of whole BCIP fraternity, I welcome you and thanks for accepting the offer. Thank you so much, ma'am. I hope all the delegates enjoy as well as take back a very good message from you. Thank you so much, ma'am.
Thank you so much, Dr. Nidhi ma'am. Now I would like to hand over stage to Prapti for further proceedings.
Hello
Prapti, please take the
everyone.
mic.
Hello. Hello.
Yes, you are audible,
Prapti, you
Prapti.
are audible.
Am I audible? Okay, okay,
Yes,
ma'am.
beta, you are
Okay,
audible.
okay, ma'am. Hello everyone. I, Prapti Kaushik, student of BPT final year, on the behalf of Banarsi Das Chandiwala Institute of Physiotherapy, welcome our eminent speakers for today's webinar, Dr. Alpna Dongre ma'am and Dr. Ishani Hanspal ma'am. I would like to extend a warm welcome to all our dignitaries, participants, faculty members, and dear fellow students. Today, we all are gathered here for an amazing learning experience. As we all know, cancer is one of the most dreadful disease which is affecting the physical health of the patient. Cancer rehabilitation helps the patient to restore and maintain their physical and psychological well-being. So let's begin with the session. I would like to introduce our first speaker, Dr. Ishani ma'am. Ma'am will be sharing her profound knowledge on pathogenesis, classification, physiological effects, diagnosis, management, and oncologic emergencies in cancer patients. Dr. Ishani ma'am, she is faculty at Sri Balaji Medical College, Chennai, and consultant lifestyle diseases at Total Rehabilitation, Chennai. She is graduated from Balaji Medical College, Bharat University, and done her post-graduation in community medicine from Rajiv Gandhi University of Health Sciences. She is having 7 years of work experience. She had her training in global adolescent health from University of Melbourne and education in research methodology and biostatistics from St. John National Academy, Bangalore. She has published various research articles. So I would like to call Ishani ma'am for sharing her profound knowledge. Over to you, ma'am.
Thank you, Prapti. Am I audible?
Yes, ma'am, you are audible.
Thank you, Prapti, for the lovely introduction. It's great to be here with all of you. And yes, so as you have already told, I specialize in community medicine, and my special interest is in preventive care. And with keen interest in non-communicable diseases, and a lot of my work has also been in non-communicable diseases. Cancer has always been an integral part of it, and I have closely worked with a lot of issues related to cancer. So yes, I hope I will be giving you insights which are going to be useful for the rehabilitation that you're going to dive into the deeper concepts of it. So yes, let me begin the session. 2 days ago, on 4th of February, was the World Cancer Day, and today we follow this up with a webinar on cancer rehabilitation. So we are doing our bit to stay with the celebrations of the World Cancer Day. The the UICC, which is the Union of International Cancer Control, as well as the World Health Organization, has recently done a survey where they assessed the impact of the pandemic, the COVID pandemic, on cancer care. And the findings were astonishing. Actually, they were much expected because the report says, most of the frontline staff being directed towards the COVID care has caused a lot of cancer being diagnosed at later stages. There were shortages in diagnosis, shortages in treatment, as well as research related to cancer. So according to this report, a lot of cancer in the coming future, a lot of cancer is going to be diagnosed at a very later stage, or might just go undiagnosed. So when cancer is being diagnosed at a later stage, most of the care is going to be palliative care given, and rehabilitation is going to play a major role in that. So what we are doing today with our, sorry. So today, with the World Cancer Day of February, the theme being I am and I will, our participation in today's cancer rehabilitation, we are doing our bit, because together all our actions will matter in reducing the further growing burden of cancer which is happening. So what I am going to do today is what I'm going to be doing is setting the stage with the basics of cancer. We're covering topics such as pathogenesis, as well as the treatment, side effects, what happens in cancer. So this is before I'm going to set the stage before you dive in deep into the concepts of cancer rehabilitation with Dr. Alpana. So let's begin. Cancer is a large group of diseases that can start in almost any organ and any tissue of the body. What happens here is there is an abnormal growth of cells. Abnormal cells start growing uncontrollably, and they leave their boundaries of the organ as well as the tissue and spread to the different parts of the body. And when these abnormal cancer cells spread to different parts, it is called metastasis. The cancer is said to metastasize, and metastasis is one of the major causes of death in cancer. According to WHO, cancer is the second leading cause of death globally. And as you can see in the table down, these are the top 5 cancers among men and women. However, according to the report of the Indian report, the 2020 Cancer Registry report, which is set out by the National Cancer Registry of India, the top 5 cancers are a little different compared to the global scenario. Lung and breast cancer being the topmost cancers in India as well, among men and women respectively. However, if you see among men, it is lung cancer followed by mouth, esophagus, stomach, and nasopharynx, which shows a general trend of the cause being increased tobacco use as well as air pollution. However, in women, breast cancer is followed by cervical cancer, ovarian cancer, and thyroid and stomach in India. What we're seeing in India is the cervical cancer is a downward trend, while breast cancer, the incidence is increasing. The number of breast cancer cases are increasing now. And cervical cancer is on a lower trend, and this is because of better hygiene, better menstrual hygiene, sanitation, as well as the vaccines which are available. Moving on to the cancer pathogenesis as well as diagnosis. Cancer is fundamentally a disease of the regulation of tissue growth. As I already mentioned, there are a lot of abnormal cells which start increasing and proliferating in the body. So in general, there is always a process of cell division going on in the body, which is kept in check by apoptosis, which is, I'm telling a little bit of molecular level over here. It's important to know what happens deep down there. So at cell division, the cells keep multiplying and growing, and to keep that in check, there is a process called apoptosis, which keeps the excess cells, growing of excess cells in check. What happens in cancer is this process, there is a break in this process. This process does not happen properly. The figure over here shows a process called carcinogenesis, which is the process of tumor formation. These normal cells becoming into abnormal cells. This is how that happens. So as I was talking, there is a constant process of a normal cell. If there's a repair, and if there's any damage, it starts repairing, and that happens by cell division. So this constant process keeps going on, which is shown over here. What happens at this stage is, if there is an insult, as in terms of a chemical exposure or a radiation exposure or a virus, this process breaks over here. These chemicals and radiations and viruses over here are substances known as carcinogens. Carcinogen is any substance which causes the cell to transform into an abnormal cell or a cancerous cell. So it's important that we look into the risk factors of cancer at this stage. The four major types are biological factors or internal factors, which are innate to us. So this is age-related, gender, inherited genetic defects, as well as skin type. As you know, certain cancers happen at an advanced stage. Some cancer, like breast cancer, is specific to women, and prostate cancer is specific to men. So these are such factors, biological factors, which pose you at risk of cancer. Environmental exposure in terms of excessive UV radiation predisposing to skin cancer, as well as fine particulate matter in air pollution predisposed to lung cancer. Occupational risk factor. Occupational cancers due to occupational risk factors account almost 1 in 5 cancers are due to this reason. And these include exposure to carcinogens such as chemical carcinogens, as well as radioactive materials and asbestols, which in turn cause cancer. Lifestyle-related factors such as alcohol consumption, tobacco smoking, and mostly these are behavioral factors, which I must emphasize are modifiable factors. This can easily be checked in by behavioral modification. So these four factors are what pose a person at risk of cancer. Besides these, radiation such as X-ray radiation also increase the risk of cancer. And the behavioral factors, as I was talking, also include some food-related habits, such as consumption of more of processed food and more of barbecued or food having a lot of charcoal in it, also increase the risk of colon GI cancer. And the chemical carcinogens also include some metals as well as plastics and tar and benzopyrene chemicals, which by working in factories, tanneries, and dye industries, such people are at increased risk of these cancers, especially skin as well as bladder cancer. Some medicines also increase the risk of cancer. People who are on long-term hormone replacement therapies or require to take hormones sometimes increase the risk of cancer in them as well. It is also very well known that cancers such as breast cancer and thyroid cancers are very much hormone dependent and related to hormones. Moving on, the process of this was the first step over here, where we saw what was the chemical radiations and carcinogens which actually cause a break in this process of cell repair and cell regulation. The next process which actually causes the cancer is promotion. What happens here is the damaged cell, the cell which is not able to repair itself, the abnormal cell starts promoting, it starts multiplying, and a lot of such cells start increasing in the body, and they progress and they spread to different parts of the body, ultimately causing metastasis. This is the process of carcinogenesis and how a cancer forms. Now, as I was constantly emphasizing that most of the factors are something which can be checked, I want to emphasize over here that 4-in-1 cancers can be prevented because most of them are by lifestyle related factors. As you can see over here, the bigger circles indicate the greater impact it has on reduction of cancer if these particular facts are checked. This is just the preventive side of me trying to emphasize how even cancer is preventable if diagnosed at an early stage. So moving to diagnosis, physical examination in terms of screening. What we look in screening is the early warning signs, the early signs of danger. And these signs, as listed in the box over here, should on a regular basis also be conveyed to the public in terms of cancer education. Everybody should be aware of these signs, and so that even a person who is not otherwise approaching a doctor and notices such signs can immediately come and seek care. So these are the warning signs which we also look at in physical examination when we are screening a person for cancer. Screening is of two types. One is mass screening. What happens in mass screening is an individual who comes to you is screened, a physician screens this person generally head to toe for all cancers. While what happens in selective screening is particular, like say a person or a woman who is above 35 years of age is specifically going to be screened for cervical cancer or breast cancer, as well as a chronic smoker, if there is a doubt of cancer, is going to be screened and looked for signs of lung cancer. This is what happens in screening. Screening is done when the disease before the disease actually shows itself. So what happens, the benefit of screening is that we diagnose the disease at an early stage so that the prognosis is good at the future. The other methods for diagnosing cancer is obviously imaging, beginning with CT. CT is done to detect as well as to check the progression. MRI is specifically done for soft tissue cancers as well as head and neck cancers because it does not use ionizing radiation. PET scan, PET, positron emission tomography is done to specifically majorly look at the spread, as in the metastasis of cancer. Ultrasound is the mode which is generally used to detect cervical cancer as well as kidney, liver, pancreas. Endoscopy is the choice when there is a suspect of colon cancer as well as GI cancers. Mammography for breast cancer. Lab tests are done to monitor blood counts. The general blood picture is done with lab tests as well as to look for specific tumor markers. Confirmation at the end is done by a biopsy. Biopsy is a large needle biopsy or a fine needle biopsy, may require ultrasound guidance, may or may not require. Pap smear specifically done for cervical cancer. These two things, they confirm the diagnosis of cancer. So this is a brief about how cancer is diagnosed as well as the pathogenesis of cancer. Moving on to the classification of tumors. Cancers are benign or malignant. Malignant is one which spreads, and benign, which is one is localized. Classification is also done by grade 1 to 4 based on the differentiation of the cells, meaning for cancer has more of undifferentiated cells, it is going to be of lesser grade, as well as a grade 4 cancer is it has more of abnormal cells in them. Grading by stage, the most commonly used method is the TNM staging, where T indicates tumor, N indicates lymph node, and M is the metastasis. T, we look at the size of the tumor and lymph node statuses, if they are involved or not, and how many lymph nodes and metastasis to which and where it is. Another way of classifying is based on the tissue of origin, which I think we are more familiar with. Carcinomas are something which are very more common, and they are from the outer layer, the epidermal layer of the skin, and they involve cancers like esophageal cancer and stomach cancer. So these are the most common cancers. Sarcomas, on the other hand, is cancers of the connective as well as the supportive tissues, and include bone, cartilage, fat, and blood vessels. Leukemias. Leukemias are cancers of the white blood cells, and they are acute and chronic myeloid leukemias and lymphatic leukemias. Lymphomas and myelomas are plasma cell cancers. And the other type is the brain and spinal cord cancers. Also, the other types are germ cell cancers also. So based on the tissue origin, these are the broad types of cancers. Moving on to the cancer management. So I'm going to be talking about the medical management because the surgical aspect is quite clear. You cut and remove the cancer out. So that's what happens in surgery, and medical management is something which I'd like to give you insight on. Beginning with chemotherapy. Chemotherapy are drugs like cisplatin, chlorambucil. These are drugs, chemotherapeutic drugs, which kill or slow the growth of cancerous cells. They prevent the formation of abnormal cells. They are used to cure as well as later at a palliative stage also. Neoadjuvant in the sense before a surgery, these drugs are given to reduce the size of the tumor. They can be given orally, all sorts of routes are possible, orally, intravenously, intraarterial. They can be given even intramuscularly and topically. These drugs can be administered. Usually given in cycles, can be also given on OPD basis, and this depends only upon examining the patient and the how the status of the patient is. Can be given on OPD basis and in cycles. Targeted therapy is a newer entrant. It is a part of precision medicine, where first a genetic study is done of a person with cancer to find out the specific genetic issue over there, and the specific targeted drug is administered over there to in the sense it is found out at what stage the cancer is in. Are the cells still dividing or they are completely mature? So that specific drug which acts on that particular stage of cell division is administered to the patient. Immunotherapy is where T cells are administered intravenously. These are biological agents which help the immune system to work in itself and try to limit the growth of cancer. So T cell transfer is done over here intravenously, is one type of immunotherapy. Moving on to radiation therapy. Radiation therapy, high doses of radiation are given externally or internally to kill the cancerous cell. The radiation is also given as a neoadjuvant therapy to reduce the size of the cancer, as well as after the surgery, it is given to prevent metastasis or further spread of the cancer. As I already mentioned, radiation therapy is of two types, internal as well as external. Internal brachytherapy is commonly used for thyroid and breast cancers, as well as systemic therapy, where it is given systemically for the entire body. Moving to hormone-based therapy, specific hormones, for example, in breast cancer, where it is hormone dependent, hormones are administered to check the cancerous growth, as well as in prostate cancer, hormone therapy is very commonly used. Now, after the medical management, I'd like to talk about the side effects that happens because of these cancerous treatments. The common ones being soreness of mouth, fatigue, nausea, hair loss, which are very common after chemotherapy. Skin changes, immunotherapy and radiation skin changes are very common. And there can be swelling, there can be pain, and there can be flu-like symptoms, as well as so nausea, fatigue, and hair fall are a baseline common symptoms because of any sort of cancer treatment which happens. A lot of weakness, a lot of muscle cramps is something which happens after cancer therapy. The table over here shows a little more of the side effects which happen as a result of cancer treatment. One thing I'd like to emphasize, steroids which are given as part also reduce the immunity and make the person susceptible to a lot of infections also. Moving on to oncologic emergency. So what is oncologic emergency? These are a group of conditions which occur directly due to the cancer or indirectly maybe due to the treatment of cancer, and which can be potentially life-threatening. Now, why is it important for you as physiotherapists to know this? Is because these emergencies are life-threatening and they sometimes manifest a little later, even after the cancer has been cured, and it can range from weeks to months. So when you are with the patient rehabilitating, you should be aware of these conditions to pick it up and immediately refer the patient for further care and management. So going into a little bit of detail, metabolic emergencies are of three types: tumor lysis syndrome, hypercalcemia of malignancy, syndrome of SIADH, antidiuretic hormone. What happens in tumor lysis syndrome is because of cancer treatment and breakdown of the abnormal cells, there is a lot of electrolyte imbalance, uric acid, hypercalcemia, hyperphosphatemia, all these electrolyte imbalances happen. And if this happens very rapidly, this is a life-threatening condition. Hypercalcemia of malignancy, again, there is a lot of calcium which increases in the body. Symptoms are such as headaches and nausea, vomiting, muscle cramps, tiredness. All of these metabolic emergencies present with these kind of symptoms. And in SIADH, there is a lot of fluid retention, and again, weakness, nausea, fatigue. Everybody complains of these. Tiredness, numbing, tingling sensations in limbs and everywhere in the body, something which is commonly going to be reported. So please keep a check on if these symptoms is being reported by a patient of yours. Hematological emergencies are such as febrile neutropenia. What happens here is the white blood cell count goes very less and there is a fear of sepsis. Hyperviscosity syndrome, as the name suggests, there is increased viscosity of in the blood which happens, and this is again due to the breakdown of the cancerous cells as a result of treatment. Structural emergencies are in the form of epidural spinal cord compression, malignant pericardial effusion, and superior vena cava syndrome. Now, all these are because of the tumor which causes compression, and because of the tumor itself causing its effects on different organs and its surrounding adjacent areas. Extravasation injuries is when the fluid or the tumor cells go into other compartments other than where they are, going to blood vessels and as well as the surrounding lymphatic channels and cause blockages over there. Gastrointestinal symptoms are very common, and we are all aware of this. Nausea being the most common symptom. It can obstipation completely. There is no passage of flatulence as well as stools is obstipation, which is also reported by cancer patients and which is an emergency. So while dealing with a patient or a person with cancer who has been treated or is being treated, please keep a check for all these symptoms being reported to you, because these are medical emergencies. Now, you are going to be talking about rehabilitation in terms for cancer. I would like to introduce the concept of prehabilitation in cancer. Now, what is prehabilitation? Cancer prehabilitation is a process which involves intervention, which assess the patient who is going to undergo diagnosis or treatment of cancer and prepare him for that physiological and the physical stress that he is going to endure as a result of the disease itself, and for the treatment, chemotherapy and the radiation that he is going to undergo is going to pose a lot of stress. So in prehabilitation, you prepare this person to endure that stress so that the outcome is going to be much more favorable. The aim is to optimize the patient's health before starting the acute treatment of cancer. These interventions are delivered by a multidisciplinary team. It involves everybody, an oncologist, a nutritionist, exercise therapist, a physiotherapist, a social worker, genetic. As you can see, the picture demonstrates over here, there's a lot of people who are involved in this. And interventions, the main aim of this intervention is to build up the cardiorespiratory fitness of the patient. If there are any nutritional deficiencies, to build up those deficiencies of the patient so that the patient's body is capable of enduring the stress of the disease as well as the treatment. So the graph over here shows what happens to a patient with cancer when there is prehabilitation, with prehabilitation and without prehabilitation. As you can see over here, the general health of the patient remains higher when there is prehabilitation given to the patient. So as soon as the cancer is diagnosed, a check into the cardiorespiratory fitness of the patient should be done. If there are any deficiencies, they should be checked by incorporating physical activity or prescribing, improving the lung capacity or doing whatever is required, and then push the patient towards treatment and further recovery. So as you can see, the life with cancer and beyond treatment is going to be with a greater health. So as I already mentioned, the benefits of rehab are many. So the improving cardiorespiratory fitness will in turn lead to a reduced length of stay in the hospital and enhance the quality of the life of the patient. These interventions of rehabilitation should be tailor-made. They should be specific to each patient, whichever component, say cardiorespiratory fitness or nutrition, is up and down for the patient. That particular intervention needs to be given to that particular patient. And these will result in greater improvements in terms of the psychological well-being and quality of life of the patient in longer run. I'd like to emphasize that in the different modalities that I mentioned for rehabilitation, say nutrition, say psychology, say psychiatry, dietitian, these are specific and will be tailor-made. However, physical activity is almost always prescribed to every patient undergoing rehabilitation. Here, this is where you need to be aware that physiotherapists play a very important and considerable role in the multidisciplinary team to have a good outcome of a person with cancer. So that's it from my end. Thank you. And I hand over to Dr. Alpana.
Thank you, ma'am. It was a nice session.
Hello.
Hello.
Hello. Am I audible?
Yes.
Okay. Thank you so much, ma'am. What an informative session it was. Thank you so much for illuminating us about the different aspects of cancer treatment and emergencies in such a clear and demonstrative way. There are some questions for Dr. Ishani, ma'am. We will take them at the end of the session. Uh, Moving ahead, I would like to introduce our next speaker, Dr. Alpna, ma'am. Hello.
Hello.
Hello, am I audible?
Yes.
Okay.
Yes,
Ma'am
Prapti,
will.
you are audible. You can speak.
Okay, ma'am. Okay. Thank you, ma'am. Ma'am will be sharing her immense knowledge on the topic clinical guidelines of physiotherapy practice in cancer rehab, role of physiotherapist in clinical management of consequences of chemotherapy and radiation therapy, and management of post-operative sequelae, designing and demonstration of exercise program for cancer patients. Dr. Arpana ma'am, director at Total Rehab, Chennai. She is graduated from Government Medical College, Nagpur, and post-graduated in orthopedics and sports physiotherapy from All India Institute of Physical, Medical and Rehabilitation, Mumbai. She has 27 years of clinical, academic and research experience. She has rehabilitated more than 15,000 plus patients till now. She is also a member of Spinal Rehabilitation Committee of American Back Society. She is the only Indian physiotherapist to have this privilege. She worked in different countries. She has various research articles in scientific journals and published book for physiotherapy students. Now, I request Dr. Alpna ma'am to carry forward the webinar. Over to you, ma'am.
Hello. Good evening, everyone. Thank you, Prapti, for your beautiful introduction. Am I audible to everyone?
Yes,
Yes,
ma'am.
ma'am, you are audible.
Thank you. Thank you. So we have heard Dr. Ishani talk about the cancer medical management, which is very much necessary as a physiotherapist for us to know the medical part as to what is the grading, what is the stage, what is the type of cancer, what is the chemotherapy or the radiation the patient has received, because that is how when we then that decide that helps us to do the exercise prescription for the patient. Because as we will go with the presentation, you will see exercise is the mainstay in cancer rehabilitation. Now, how do we plan the exercises? What are the factors to be considered? All those things I'm going to talk to you. So let me start without wasting further time. And see, as Dr. Ishani has already told us, here you can see in India in 2020, it was like 94.1 males out of 100,000 were affected with cancer, whereas 103.6 females out per 100,000 was the number. Now, lung cancer, as was told to us, yes, 1 in 68 males have lung cancer and 1 in 29 females with breast cancer. And it is predicted that 1 in 9 will develop cancer during their lifetime in India. This is, I'm talking about the Indian statistics. So it's a little scary when we see, but then, like, I'm not going to go into that aspect. The statistics I talked to you here, it is because now when the number of the number of cases with cancer are more, but at the same time with improved medical management, there is an increase in the cancer survival rates. So more healthcare intervention is required to improve the quality of the life of these people. See, medical management is done, the patient's life has been provided, but then there has to be a quality to this life. That is where when we come into the picture. And for this, we need a good rehabilitation facility during all the stages of survivorship. a patient who has undergone a treatment for cancer, maybe surgery, maybe chemotherapy, maybe radiotherapy, and after the treatment over, the patient is in the stage of survivorship. So what is cancer rehabilitation? It is a medical care which is integrated throughout the cancer care period given by the trained professionals, and it includes diagnosing, treating the patient's physical, psychological, and cognitive impairment. Now, what is the purpose of cancer rehab? It is to maintain or restore the functions pre-disease, reduce the symptoms burden, maximize the independence of the patient, because once a patient, like we all know patient, once they get diagnosed with cancer, psychologically the patient feels too low. The patient tends to become dependent on small things, and even the treatment also does make the person dependent, like they don't remain physically so active, so the quality of life comes down. So the cancer rehab is basically to bring the patient out of all these phases. So what are the clinical guidelines of physiotherapy practice in cancer rehab? Now, cancer-related physical impairments, we need to see this first. They are classified under 4 categories: musculoskeletal, neurological, pain-related, and general. So what are the musculoskeletal? Like you can see, those are the reduced bone mass, muscle mass, motor performances are impaired, and the radiation fibrosis. Neurological are nerve impingement, peripheral neuropathy, autonomic dysfunction, spinal cord compression, ataxia. Pain related can be site specific pain, or it can be a chronic regional pain syndrome. That means the complete area, the complete part, like, for example, if the patient has got a breast CA and the patient has undergone a radical mastectomy, there can be a pain in the shoulder, in the scapular region, in the arm, forearm, and the hand, the complete thing. This is known as CRPS. And general is fatigue, overall deconditioning, low mood, stress. Now, how do we classify the oncology rehabilitation or the cancer rehabilitation? Goes in 4 phases. There are 4 phases of rehabilitation. Number 1 is the prehabilitation, that is from the time of diagnosis till the patient is started with the treatment. During that phase is prehab. Restorative rehabilitation is the time when the patient is undergoing the treatment. Supportive rehabilitation is after the treatment is over. That means patient has undergone surgery or radiation or chemo, whatever, and then the patient is there for rehabilitation. And then the palliative rehab is where the disease has been advancing. It is the end of life care. Progressive cancers, that's where the palliative rehab comes into picture. And who benefits? The preventive rehab, as I told you, is the people, the patients, those who are waiting for treatment to start. Those are the patients, they are under the preventive rehabilitation. Restorative rehab is like the patient is undergoing the treatment. So here we are positive with the outcome of the treatment. We expect this patient to restore the functions fully. There has to be a good recovery. So these are the categories of the patients where we are expecting a good recovery to happen, as there has been a medical management done. And we are now entering into the scene for the restorative rehabilitation, trying to restore their functional status. Supportive rehab is for the patients where now the medical management is over. There are still certain deficits, either because of the cancer or because of the treatment. They remain with the patient, and we help this patient to overcome those, say, the effects because of the remnant cancer or the treatment effects. And palliative rehab is for the advanced diseases. Now, the rehabilitation starts with assessment. We don't just have like, okay, fine, the patient has come into the stage of rehab, restorative rehab. Okay, patient has undergone a breast surgery, right? Breast surgery, this is 1, 2, 3, 4, 5. This is to be done. No, as we'll go further, you will see any management, rehabilitation management, that we always apply a principle of individuality. That means every treatment plan or the rehabilitation protocol plan is individualized. It's not the same. It's not generalized saying breast rehab, this is the management, or oral cancer rehab, this is the management. No. So here we need to have a medical history of the person, that is the cancer history, medical comorbidities. The patient may be having other comorbidities like Patient can be asthmatic, patient can have degenerative conditions, patient can have diabetes or hypertension or some hormonal disorders. Drug-related side effects, the patient has already been put on, say, the drugs for the management of cancer. So those side effects might be there. Each person is not going to have the similar side effects, and then the clinical examination. Now, the social history also we do need to take from the patient as to what is the age of the spouse and the health of the spouse, because that is the support system with the patient. The children and the siblings, do they stay with the patient or is the patient staying alone? So that helps us to decide the rehab program. Like, if they stay with the children, we have a different approach towards the rehab. If they stay all alone, we have a different approach. What are the physical environment at home? Are there railings for the safety? Is the bathroom safe? So these all things are important for us because that helps, that is where our rehabilitation is dependent on. Sitting and standing balance, transfers, gait and walking aids, and then the activities of daily living. Which activities of daily living is the patient independent, and for which activities the patient requires the help. The clinical examination we do need to do. Very specific cancer-related clinical examination should be done for all, which is the general performance, where we try to find out what is the quality of the life the patient is leading post-treatment or post-diagnosis. So there are functional, those outcome measures like SF36 can be used. Mobility and balance has to be assessed, pain, fatigue, cognitive functions, and the area-specific examination. Now, let's come down to the what are the guidelines for the rehab planning. When the pre-treatment stage, that means the prehab, what are the aims and the objectives? The aims of prehab are the improvement of the general functional status of the individual, because this is the phase where the patient is waiting for the treatment to be started. The patient has already been diagnosed, and from the diagnosis to the treatment, that phase is very important. If we are able to build up a good physical, psychological, and emotional strength for the patient, the outcome of the treatment intervention is very good. So we have a very major role to play during this phase of diagnosis to treatment. Improvement of general functional status, prevention and attenuation, that is diminishing the functional decline during the treatment. During the treatment, we know that the patient is going to be functionally low, coming low. There is going to be a fatigue, there is going to be a physical deconditioning. So we try to reduce those effects to the maximum by intervening during the rehab phase. Assistance to the individual to emotionally and psychologically face the disease. So what are the objectives? These are the aims. That is why we intervene. Now, what are the objectives of our management here or our intervention? Maintenance of the muscular mass and strength, maintenance of the cardiorespiratory function, maintenance of ADL, and optimization of the immune function. Now, during the treatment stage, the patient has already now taken up for the treatment, and during the treatment phase, we are still there into the scene. Why? To reduce the collateral effects and toxicity of the treatment, to maintain the physical functions and the body composition. That means the patient should not be losing a lot of weight, or the patient should not be putting, the BMI should not just increase a lot. So we come into the picture to ensure that we are keeping a check on all those things, to maintain or improve the functional capacity and the muscular strength, to maintain the quality of the life, facilitate the treatment conclusion. The treatment is going to be sometime or the other, the treatment has to conclude. That means the medical management has to be stopped, and then the patient has to be brought to the normal life. So that we help the patient to come out of this treatment intervention by making him respond positively to the treatment, to boost the efficiency of the treatment. Now, what are the objectives? Like we are doing it here. We attend to the pain, fatigue, muscular weakness, ADL deficiency, balance and coordination, lymphedema, peripheral neuropathies, osteopenia, and myopathy, which is induced by the steroids being given to the patient. So our intervention during the treatment stage is like, it takes care of all these things. This is the area in which we should be working on. Now, once the treatment phase is over, Let us say the patient has been on chemotherapy for, say, let us say the patient had 3 weeks of chemotherapy, or the patient underwent a surgery, and after the surgery, the radiation and all everything is like 6 weeks of. Excuse me, can you please put on the mic? Somebody is talking. I want the mic to be put off for that person. Okay, so here it's like post-treatment stage. The aim of the why we are coming into the picture is return to the pre-diagnosis physical levels of functional capacity, reduce the risk of remission and the onset of other diseases like hypertension or diabetes, to develop exercising habits, which is very important for a person who has been diagnosed with a cancer and undergone a treatment, and extend the survival rate with the quality of the life. And how do we do this? We take care of the improvement of the body composition, improve the muscular strength and endurance, cardiorespiratory fitness, flexibility, and the physical functions. So during all the stages of our intervention, during pre, during, and post, exercises remain the main intervention. Now, the next role of physiotherapy in clinical management of the effects of chemotherapy and radiation. We were first seeing the cancer, like for the cancer, what is our role to do? Now, the patient has undergone chemotherapy and radiation therapy. There are effects of chemotherapy and radiotherapy, and how do we manage those effects of the treatment? So, what are the consequences of chemotherapy? Fatigue, easy bruising and bleeding, infection, peripheral neuropathy, skin and nail changes, weight changes, and if there is a chemo to the brain, then the concentration and the focus of the patient and mood changes. Now, these things how do they make importance for us? Fatigue is, yes, that is very clearly understood that if the fatigue aspect has to be attended in order to improve the physical efficiency and the functional capacity of the individual. Easy bruising and bleeding, infections, these things they help us in deciding the exercise program. If the patient has been put on chemotherapy, there is a possibility of these things happening. So we plan the exercises accordingly. We don't go for very harsh exercises which can lead to intramuscular bleedings. The patients need not be in groups. The patient need to be segregated because there is a high chance of infection developing into them. Consequences of the radiation therapy is again fatigue, decreased range of motion due to the radiation fibrosis of the tissues. Radiation to the chest affects the underlying lung tissue, causing shortness of the breath and radiation pneumonitis, difficulty in swallowing, shortness of the breath, shortness of the exposed soft tissue, soreness, skin sensitive problems with the memory, and secondary cancers such as skin cancer. So these things post radiation, I had a patient in between with CA breast. She underwent very beautifully through her chemotherapy. She underwent her surgical aspect very good. It was the radiation where she's really suffered. It's mainly because the fibrosis which got built up, it pulled her down. It brought down her the morale. It brought down her physical efficiency a lot. So this radiation fibrosis is something where we need to start working from the day one. The cancer-related fatigue. Every patient with cancer, either because of the disease and because of the treatment, both the reasons they contribute towards the fatigue. So when the patient has this fatigue factor set in, the patient tends to become physically inactive. That is sedentary behavior. And that leads to physical deconditioning, which causes the muscle wasting, and that again further leads to more fatigue. So there's a vicious cycle of fatigue which builds up into the patient with cancer. And this fatigue reduces the quality of the life. It increases sleep disturbances, psychological distress, cognitive dysfunctions, and reduces the overall energy levels. Now, what are the different types of deconditionings which happen? The cardiopulmonary, muscular, bone and collagen, and metabolic. So all deconditioning happens at all the levels, and this leads to reduced VO2 max, reduced exercise capacity, increase in tendon injuries, increased cardiovascular disease, increased risk of diabetes type 2. Like we need to know these because this is where knowing well that the patient has got a exercise planning has to be done accordingly. We need to really plan the exercise in a way where we are not further encouraging the deconditioning process. Again, patients who undergo chemotherapy and radiation, there is the issue of balance and coordination. So these patients, because they become like, there is a limited independence. The patient, because of the fatigue, this patient has limited independence. They become dependent, and that leads to decreased postural control, because for everything, even to get up and go to the bathroom, they try to take somebody's help. They try to either hold the wall or hold somebody's hand, or they take a walker. Like, psychologically, it's like they're inside, like, I have cancer, I had been treated for it, and I am like, it's not good. So that itself pulls them down. Plus, the effect of the treatment and the disease is definitely causing them the low energy levels. So that causes decreased postural control, decreased gait speed, because posture and balance is affected. So the speed of the gait reduces. This causes further reduction in their physical activity participation. They don't get actively involved into many physical activities because the gait is reduced. So posture is not good. The imbalance is there, and that keeps them aloof from physical activities. This leads to physical deconditioning, and that causes furthermore fear of falling, further remaining away from the activities. So it's a cycle. And as physiotherapists, when we intervene, we reverse this cycle. We reverse this complete cycle by increasing the posture control and balance, and increase the physical participation of the patient into various activities. Now, for the static balance, the intervention which is normally suggested is close kinetic chain exercises, sensory motor training, and core exercises to improve a static balance into the individual. These things are important. And then the dynamic balance is improved by gait training, balance obstacles. That means while the gait training, we keep certain different obstacles in between, and we ask the patient to bypass them and move forward without losing the balance, or without touching the obstacle, or without letting it fall. Mechanical alterations here mean it's like, maybe we make the person walk straight, and then we ask the person to be like, say, take one leg up and then go around, or the patient has to be holding something in the hand, and and then change the weight bearing and then keep going forward. So these are mechanical alterations. Next, again, because of the chemotherapy and radiation, there is a bone loss. So whenever this management of the bone loss also is done, whereby if we do the DEXA scan for the patient, DEXA scan T score, if it is more than -2, and if it is less than -2. So if it is more than -2, there is exercises, calcium and vitamin D to be given to the patient. But if it is, that means it is osteoporosis. If it is less than -2, it is osteopenia. And there it is exercises, calcium and vitamin D, plus there are other drugs which are being given, bisphosphonates and all, which helps in the synthesizing of calcium into the bone tissue. Next, we come to role of physiotherapy in clinical management of post-operative sequel. So post-operatively, what are the late effects of surgery? Scarring of the surgical site, problems fighting infection, lymphedema, nutritional problems, cognitive problems, pain that may be chronic or long-term, and difficulty with speech or swallowing. So these are the areas where these are the late effects of the surgeries, and we need to start working on it immediately post-treatment. The areas to be addressed post-operatively is mobility of the tissues by myofascial release techniques, flexibility training or electrotherapy. Strengthening of the muscles is kinesiotherapy and electrotherapy. Cardiorespiratory conditioning is breathing exercises and aerobic training. Pain management is exercise therapy, electrotherapy, nutrition, and then there are other behavior and psychological psychotherapies. Now, this is where I guess it's like, everybody might be really looking forward to this. How do we design the oncology exercise program? What are the factors to be considered here? The exercises for oncology rehab are moderate intensity, aerobic and resistance training, which is regularly done. And the outcome of these exercises, intervention of exercise, is reduced cancer-related fatigue, reduce physical deconditioning, reduce psychological distress, and improvement in the quality of the life. So those are the same things which I have just put it up here in the words that was in the pictorial form earlier. fatigue reduction has to be the first and foremost say aim, and it is the benefit also. One more thing you can see. Yeah. So, like, the exercises actually reduce the amount of analgesics the patient is supposed will be taking, and that reduces the hospitalization time of the patient. Now, what are the risk factors of the exercises? Like when we plan the exercises, we need to take into consideration immunosuppressive potential. Because of the chemotherapy, the patient is the immunity has been compromised. So we need to take that aspect into consideration here. Probability of the fractures, cardiotoxicity exacerbations caused by chemo and radiotherapy. So this cardiotoxicity issues is a cardiomyopathy. Cardiomyopathy following chemotherapy and radiotherapy can happen even after days, months, or even years after the treatment is over. So this we have to always keep in mind that yes, this is a one factor which we have to look into, and exercises should be based on that. We should always keep looking for the signs of abnormal response of the exercises: pain, nausea, fatigue, and intolerance. So now exercise testing is important. Why we do the exercise testing is to know the muscle strength and endurance and to know the cardiorespiratory function. Then plan the exercises. But before the exercise testing is done, we screen the patient. And the screening is done to assess the inherent risks in the individual. That means the patient may be having certain comorbidities, or there may be a potential for a cardiovascular event. So that is where the screening should be done, whether the patient has any comorbidities, there are any other factors, or the patient has got some old, past history of angioplasty or CABG or hypertension. Those things should be looked into. Risks related to anti-cancer treatment or the treatment-related side effects, that is anemia and cardiomyopathy, and risks associated with exercise intervention, that is with what is the intensity of exercise we are going to intervene with. So these are the general precautions or the contraindications for the exercise training. The contraindications are, like you can say, the surgical wounds. If there is already a wound which is not healed, or the patient is just 24 hours following chemotherapy or radiation therapy, or if there is any immunosuppression, fever, nausea, vomiting, calf pain, peripheral neuropathy, sudden onset of muscular weakness or fatigue. See, patients will always have a fatigue there, but then if there is a sudden onset of too much fatigue, that is where we need to stop the exercises. The patient has got sudden onset of dyspnea, or there is ataxia, balance deficiency, dizziness, blurred visions, disorientation, irregular heartbeat, palpitations, cardiomyopathy, all these things, like, that is, these are all the contraindications to exercise training. What are the considerations? Now we have seen all that, and now we want to plan the exercise. So what should we look into it? Principle of individuality. That means every patient is an individual. Every patient will have a different exercise plan for him. Adaptability. That means the exercises have to be, the patient has to get adapted to the exercise intensity, exercise type should be such where the patient can adapt to the exercise, and also there has to be certain adaptation into the exercise pattern also, depending on the patient's medical condition. Specificity. What do we want? We want the patient's cardiorespiratory function to improve. Exercise specific to this. I want the patient's big muscle, the quadriceps, to be improving. Specific exercise. It is a principle of specificity. Principles of reversibility. This means as long as the patient is continuing to be trained, the patient will have an improvement. But the moment the patient stops, it just reverses back. So this is always going to happen. So we should keep this in mind and accordingly plan the program, whereby, because there is always a possibility, sometimes the patient may not do the exercises, or the patient will not turn up for your exercises, and there will be a break of some period in between. Whenever there is a break, there is always a reversal. So we should plan the exercises in such a way that they are not so intense that the reverse phenomena happens like a rebound, and we actually reach the beginning every time the patient comes back after some interval. Principle of overload. So let us say if we are working on the quadriceps of the patient, and if the quadriceps muscle power is found to be 3. So when we train this muscle, we need to actually overload the muscle for 3 plus. There has to be an effort to be done by the muscle, then only the strengthening happens. If the patient has got the strength 3 power and we work on 3, we are not going to strengthen. Principle of modification to the physiological functions, type and stage of the disease, medical treatment and past history. Now, how do we progress with the exercises for these patients? Free, at first, it has to be free active exercises. Progress to gravity resisted exercises, progress to endurance training, and then is the last, the strength training. We don't start with the strength training from day 1. There has to be a 48 hours of rest period between sessions. So what we do is, I'll tell you how do we plan the exercises so that there automatically there is a 48 hours of rest period. It's not like the patient comes today and 2 days the patient sits at home. It's not like that. We plan the exercises like one day the aerobic, then one day the fitness, the strength training, one day the flexibility training. So automatically there comes a rest phase. And 1 to 2 sets of 8 to 10. There has to be only 8 to 10 exercises. That's all. It should not be too many exercises all of a sudden. And these exercises, 1 or 2 sets depending upon the efficiency of the person, and that should be done twice a week. If the cancer-related fatigue is very prominent, then we give only 3 or 4 exercises to the patient, only 1 set and 5 times a week. So every day, 3 to 4 exercises, only 1 set is done. And then that continues, and then gradually it is progressed. Now, it has been found, the research has found, if the patient has got a cancer-related fatigue, in these patients, if the fatigue factor is there, then aerobic and resistance training given together has got a very short-term benefit. But if we want a long-term benefit on the fatigue factor of the patient, then it has to be only a resistance training. Aerobics should not be added to it. Alterations in exercises for the severe cancer-related fatigue, the CRF. Now, if the patient has got a severe CRF, so here what CRF is identified by the RPE scale, that is the rate of perceived exertion. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I hope you know. And with that, then we know, okay, fine, the patient is like, 1 to 3 is minimal and mild, and 3 to 5, 7 is moderate, and 7 to 10 is vigorous or severe. So low to moderate intensity exercises are, if the patient has got a severe CRF, that means RPE is between 7 to 10, then low to moderate intensity exercises are to be done, which means it is 50 to 60% of the maximal capacity. How do we identify the maximal capacity? It is 220 minus the age of the individual. So if the person is say 62, so 220 minus 62 is 158. So 50% of 158 is like, 158, 50% is 75 and 479. So we reach the heart rate level of 79 for doing the exercises for that individual. That is the limit. This is how we calculate. The shorter duration of exercises, it is 10 minutes at a time. Interval exercises, like, there is an exercise done for say about 3 minutes, and then we give a break of 1 minute in between. And then again, we have an exercise. So it's an interval training being done, and exercises during the days. That means when the patient has got a chemotherapy, those days we don't do the exercises. On all the exercises, they were more, patient is much more comfortable doing them in the morning hours because fatigue is at the lowest. Now, what are the guidelines for the exercise prescriptions? We have seen all those details based on that. Now, this is all like a tabular form it has been put up. So it is like, these are the parameters we need to look into. What is the type of exercise? What is the frequency of exercise? Duration, intensity, and how do we progress? So this is also known as the FIT principle. FITT. F is frequency, I is interval, T is intensity, I is intensity, T is time, and at next T is the type. So type of exercise, duration of the exercise, intensity of exercise, frequency of exercise is FITT, and then the progression. So to start, we always start with the big muscle groups, that is, or the proximal muscle groups. Alterations are made depending on the treatment. Frequency of exercises is 3 to 5 days a week. And if it is a deconditioned patient, that means there is a lot of fatigue element into it, then it has to be done daily, but duration of exercise is smaller. Otherwise, if the fatigue factor is mild or moderate, then it is 20 to 30 minutes. And for deconditioned patient, as I told you, it is interval training. Intensity of the exercises is moderate, that is 50 to 60% of the maximum heart rate, and depending on the fitness level and the treatment. Progression, initial progression of exercises is done with frequency and duration. That means number of times the patient is doing the exercises is to be increased, or the duration of exercise to be increased. The intensity, that means increasing the resistance, should be done only in the later stage when the patient is able to overcome the frequency and the duration. So this is what the FIT principle I told you earlier. The same thing is here, which is like, the frequency, intensity, duration is again the time and the type. So what type of exercises is large group of the muscles are always used. And then the aerobic fitness must be the three things. It is always aerobic fitness, that is the cardiorespiratory. Muscular fitness is the muscle strength and endurance, and the flexibility. So all the exercises have to be planned in these three. Now you can see here. See, aerobic fitness goes for 2 classes per week. Muscular endurance and strength training is 1 class per week. And flexibility, that means the stretches and all, happens 3 class per week. So 3 and 2, 5 and 1, 6. So here you can see the patient is actually doing exercises all the days. But then again, there is an interval. It's like 48 hours of interval we need to give. It is automatically coming here. So now I'd like to share with you one case. Like, we had a case of CA breast. Yes, here. So this lady, she had a radical mastectomy. She was 62 years old lady who was a case of bronchial asthma, prior to childhood bronchial asthma. And she underwent this thing, triple negative type of the cancer was there. Following this, she had chemotherapy first, and then she had a surgery. And then she came with these type of drain tubes. Now, with this drain tubes there, the intervention, what we did when this patient came, she came to us during this phase. That means if at the post-operative phase, she came to us. And previous to that, she was just coordinating with us over the phone. So when she went for the surgery, she was coordinating over the phone as to the cardiorespiratory functions we were helping her to overcome. And so here, if you can see these arrows, that is the manual, see, MLD is manual lymphatic drainage. So we drain the lymphatic fluid, which is very much essential. So here you can see, it's like, because these all axillary lymph nodes are removed out from the patient. So from here, it is being pushed towards the other side. Then from down, it is being pushed towards the submandibular lymph nodes. And from the axilla down here, avoiding the scar, then it is brought down towards the tube, where from there it is coming out. And like, it was so nice to see when we were draining it. I could really see with this draining techniques itself, like, almost around 10 cc of the fluid was getting collected. We could see the fluid coming out from the tubes into the tubes. And following that, she was very comfortable. Her hand movements used to become quite easy. Her breathing became easy. So when this patient is like during the first stage, the initial stages, when she came immediate post-op, the wound, there was a little bit of healing still to happen. There's a lot of scarring which happened for her. And so this area which was healed, we were just doing like, say mild, say soft tissue, say mobilization here in order to prevent any sort of fibrosis happening. And this area which was still having the wound not healed, so we left it as it is. Now I would like to here show you the MLD, because this is something which requires everybody to know, like, when you work on the MLD. So I'll show you on my hand itself, like, when you are here. So you need to drain the lymph towards the lymph nodes. So now the draining is like, if you see this, and the pressure has to be just sufficient enough to literally just to give a stretch to the skin. It should not be pressed and then move. There should not be a depression onto the skin. There has to be a mild stretch felt on the skin, and then the drainage. So when you do this and repeat it, say till you can really feel the underlying tissue has become softer. It happens in around, say, 7 to 8 movements. You can really feel the tissue has become soft. That means the lymph has drained out from that particular region. So here, okay. And so how do we do it? It's like the breast cancer patients, before we start with the lymphatic drainage for them directly, it is first the surrounding lymph nodes should be activated. So now, as you know, like, you know, these patients where the complete axillary lymph nodes have been removed, in some patients, the supraclavicular lymph nodes are also removed. So then what the mediastinal lymph nodes may also be removed. Depends, like, you know, we need to see their surgical nodes and understand. So what we do is we are left with the submandibular lymph nodes. We are left with the celiac lymph nodes, which is around the umbilicus. We are left with the lymph nodes on the opposite side. So the thing what we do is we stimulate the lymph nodes on this side first. So just small circular movements are done, not deep pressure. You just need to do small, very light circular movements, say 8 to 10 times in one direction. It should not be just anywhere like this. No, it just goes in one direction. So it activates the lymph nodes there. Then for the celiac lymph nodes, that is, which are there around the umbilicus, you need to do a diaphragmatic breathing for the patient. So when the patient breathes in, the abdomen needs to be pushed out as much hard as it can be, and then breathing out, the abdomen is pulled in. So this pulling in and out of the abdomen causes the lymph nodes there to get activated. Inguinal lymph nodes also need to be activated, because that is where then again we drain the fluid. So again, inguinal region, the same how we did it into the axilla, the same in the inguinal region, we need to slowly say activate the lymph nodes. Once this is done, then the fluid is being, like, you know, as I told you, it is just a stretch of the skin. It is not a deep pressure, just a stretch of the skin. Take it and then drain it towards the opposite side. Just drain it towards the opposite side lymph nodes. Or from here, if it is there, just take it up to the submandibular lymph nodes. It is down lower part of it. The lower part of it, when you do it, it is from there. We just take it and we bring it down to the inguinal lymph nodes. So where is it, like, you know, from where is the closest lymph node, push it into that particular direction. For the patients where you need to drain into the inguinal lymph nodes, it is always required for them to undergo stretching of the hip flexors and the hip extensors contractions. So that is where say the lymph node will be always activated. They will be able to receive in the excess lymph coming over there. So with this, I like to close, because, you know, this is in general we went, and any specific, like, you know, CA breast or CA oral cancer, oral cavity, you know, then it becomes a very specialized management of to how do we plan, what are the interventions and all that stuff. So I'm open for the questions, any? Hello?
Hello.
Yes.
Yes, thank you so much, ma'am, for sharing such a valuable information with us. This will surely help us a lot in seeing towards the cancer patient through a completely different perspectives. So before concluding this session, ma'am, we have some questions by the audience. So going ahead with few questions we have. Kindly explain mass screening and selectively screening again. Ishani ma'am.
Yes, Prapti. Mass screening and selective screening, is it?
हाँ जी ma'am.
Okay, so as I'd already mentioned, screening is something which involves physical examination of the patient when he comes to you. And so in mass screening, what happens is the patient is screened at a general level, as in all cancers are looked for in the particular patient when he comes to you. So a head-to-toe examination is done in the patient, and specific, like if the oral cavity is looked for any pre-neoplastic changes, any sublingual fibrosis or leukoplakia will be something specific to the oral cavity. Similarly, thyroid region, breast, if there are any lumps. So this is in general at a population level. So that's what we mean by the mass screening. So in general, when there are, say, camps conducted and people just walk into your camp, and that's when they are generally look for any sort of cancerous change or any early warning signs that I have put up in the box. Any of those warning signs which are present, that is what we look for in mass screening. In selective screening, the selective is specific to the cancer. So the most common type of cancers are lung cancer, breast cancer, and cervical cancer. And what we generally do here is specific to these. So when a lady who is about 35 years of age or is from a lower socioeconomic status, so their cervical cancer is common, and above 35 years, breast cancer is common. So there specifically we look for changes in the breast, and over here we'll inquire or maybe do a pap smear or maybe do any sort of examination, TB examination for the cervical cancer. And again, if a chronic smoker comes in, so we will look specifically for changes in the lung cancer. So the mass and selective is specific to the cancer over here where the screening is done.
Okay, ma'am. So the next question is persistent fibroadenosis severe and how it can be treated?
Fibroadenosis is a benign condition which is usually presented as a lump in the breast, and it is very, very rare that it transforms into a malignant sort of a tumor. Fibroadenosis is benign most of the times, even if it is persistent. What the patient has to do is do a self breast examination on a regular basis and make sure that the lump is of a similar size and similar texture. In case there are any changes which the person examines on the self breast examination, it requires further intervention in terms of an FNAC can be done to check if the change is becoming malignant. But it is very, very rare that a fibroadenoma turns malignant.
Okay, ma'am. So the next question is, what is the success rate of cancer rehabilitation?
Dr. Altna can would be much
Hanji.
appropriate to
ma'am.
answer.
Ma'am, you are not audible.
Now?
Yes, ma'am. Yes, ma'am.
Okay, I'm sorry. I said,
Okay.
see, because we start our intervention from the time the diagnosis happens, so the success rate is it is good. Here we are giving them the quality of the life, number one. Number two, we reduce the risk of second cancer, we reduce the risk of recurrence of the cancer, we improve their functional efficiency. So it's like, you know, if the patient has not developed any comorbidities, then the success rate is excellent. Like, you know, I cannot give you an exact figure here because those statistics are not available. But then what we have been normally seeing is, like, you know, the patients, the medical aspect, it is said that every cancer patient is like the 10-year survival rate is what they look into. Here, during that period of 10 years, what we see is how much quality of life did the person have. It's always the 10 years period in cancer patients, which is being always looked into post-treatment. So from a physiotherapist point of view, we look into the quality of life for those 10 years, and that quality of the life is really good. So from a physiotherapy intervention point of view, when the rehab aspect comes, I will, if I'm supposed to, if I just based on my own interventions and observations in the clinic, if I'm going to just put it in the number form, I can say it's almost say around 85 to 90% is the success rate as far as the quality of life improvement can be done for the individual.
Prapti, your mic is off.
Hello. Hanji. Thank you so much, ma'am. So our next question is, which modalities can be safely used in cancer rehabilitation as there is a risk of metastasis?
Heat modalities are avoided.
Okay, ma'am. Please tell how to measure the strength of respiratory muscles.
The respiratory muscle alone, we are never measuring as far as cancer rehab is concerned, because cancer rehab focuses on a large group of muscles. It doesn't focus on small muscles, and respiratory muscles are the small muscles. Now, if at all somebody is very keen on seeing, I don't know why, But then if we are very keen on seeing it, like, we normally, it's just like either with the help of the measurement of the chest, this thing, the person inspires deep and how much of the expansion has happened, at which levels accordingly we identify. That is one. Or the other methods can be, it is like, even there's the PFT where the thoracic compliance is tested, and then okay, find the thoracic compliance if it is say related to the joints or related to the muscles, and then we know, okay, this much of the compliance the patient has had it, so that is where then the calculations come. But then actually the respiratory muscles are never measured when it comes to cancer rehab.
Okay, ma'am. So next question is lymphatic drainage important for before exercise, or exercises can be done simultaneously?
It can be done simultaneously. It
Okay.
depends.
Okay, ma'am. Thank you. It seems like we have answered all the questions, and I hope all the queries are clear now. Now I would like to call Dr. Kavita ma'am to give vote of thanks. Over to you, ma'am.
Thank you so much, Prapti. I think we have lost connectivity with Dr. Alpna and Dr. Ishani, ma'am.
Yes, ma'am. I think yes, ma'am.
Yes, they are not available.